thank you all to the panelists for being a part of this discussion today. And to pick up where I believe Dr. Barthwell left off, um, you were talking about phases of recovery and how it may differ across the lifespan, and I think a little bit about youth. Or am I making that up?
I think I took it into the lifespan piece because of my focus, but it was a little bit more broad than that.
All righty. Well, let's restart with a broader question, and that is whether you would talk a little bit about the facets of recovery for all age groups. Anyone like to take that on?
So I can weigh in and kind of maybe tie both questions together and weigh in from a health services perspective. And I really I spend a lot of time thinking about the substance use continuum of care. And how we can expand that continuum of care kind of on the front end, but also on the back end. And on the back end, kind of recovery support services have unfortunately been thought about as aftercare, or kind of what happens after treatment. But I think that there's also a really neat place for them kind of at the beginning of the continuum of care and helping facilitate people getting into treatment. So therefore, reaching and attaining and helping to sustain recovery earlier and extend the benefits that they may gain during their treatment experience if they're able to access the treatment system.
Indeed. I love that thinking. Would anyone else like to comment on that, on the facets of recovery?
Yeah, actually, I'm glad you brought that up because I think that's an area where we really need a lot more thinking, a lot more research. I've been thinking about the shift in definitions or understandings of problem resolution toward this concept of recovery and this recognition that recovery is this broad thing. But there are quite substantial differences in terms of how people are defining recovery. So, there have been 5 major institutions that have defined recovery over the past 15, 20 years or so, right? SAMHSA had a couple definitions, one focusing on substance use and then migrating more recently to mental health and substance use together. And then also Betty Ford, ASAM, NIDA, and IEEE, and then researchers also have convened and developed their own definitions, and there are international different definitions as well, right, from the international community. And these do have some pretty major differences in terms of whether abstinence is focal or not, and also in terms of what life domains are emphasized as important. For example, NIEE's definition is, I think, quite different from the definitions of other institutions in terms of really emphasizing symptom remission and drinking, whereas the other definitions are emphasizing broader life domains. And then all of them sort of differ from the definitions of people in recovery uniquely and specifically. So Leanne Keskudis and I have done work on her What is Recovery study, which surveyed almost 10,000 people who self-defined as in recovery or having resolved an alcohol or drug problem. And they reported on the extent to which each of about 45 recovery elements were part of their own personal definitions of recovery. And these elements came from very extensive qualitative work. And what came out. And so we recently looked at those elements that are basically universal across, every different kind of subgroup that, or the most major subgroups that you could think of based on socio-demographics, substance use characteristics, and help-seeking history. So people that recovered independently, people that recovered with treatment, white people, Black people, Latinx people, people of all different races, ethnicities, people with different primary substances and so on. And, we came up with 8 basically universal or near universal elements, which are quite different really from the elements pointed to in these universal definitions in some ways, although there are overlaps. So, and that work is in preparation now. But I think I think there's this great opportunity in the field now to think more broadly about what recovery means, and what it means for different subpopulations, and recognizing that it doesn't mean the same thing for everybody. If we widen our understanding of recovery, we have the potential to invite more people into recovery-related services, people who don't necessarily feel ready to commit to abstinence, for example, or who want some kind of broader life change and don't want to just focus on symptom remission. But at the same time, I think there's a lot of confusion around what really are our goals here then in promoting recovery, because we don't seem to all agree a lot on, what the endpoint should look like, and how should we integrate our current strategies with a system that is incredibly heavily dominated by, an abstinence framing, a 12-step framing, right? Do you incorporate into the same treatment program groups that focus on moderation with groups that focus on abstinence? What happens when those people interact? Do you have, one group for everybody? Same thing with the mutual health group world that's abstinence dominated. And so if people want services outside of treatment for long-term support, what does that look like? I think, and in terms of disparities, we need to think about that as well. We didn't find large racial ethnic differences or socioeconomic differences in terms of people's recovery definitions, but I think that needs to be part of the picture as we think these things through. Sorry, that was long.
Thank you. It is duly noted that NIAAA could perhaps benefit by broadening our focus. Dr. Shido, would you?
Could I respond to Amy? Amy's comment. The response I have is like she talked about recovery services at different point. I think it goes along with, regardless of how you want to define recovery, if it's if it's about the path to recovery or whatever the definition might be, is where recovery services could have major impacts. It's like I want it everywhere, because I think Amy's right. It's from the very beginning, and I mentioned for emerging adults, having them talk to a recovery support person first instead of a therapist. And there's a ton of work that's out there that's called peer recovery supports, but when you look at it, it's really linkage facilitation. And not that we need to get like the definition, but yes, that's a place for them. But I think that there are a lot of people out there in the real world that a lot of studies are around the linkage facilitation piece, but there are a lot of peer support workers out there that are doing a ton more stuff than that, but they're doing it at various places. But then a lot of funding is pulling peer supports to be attached to treatment, an episode of care. And it's that post episode of care, I think, is a huge gap that we see where youth and young people, and especially families, needing supports to have some sort to help them maintain the recovery, whatever the definition might be of the recovery that the person has achieved, and not just family members, but other social supports that want to help an individual maintain that recovery. And that's where recovery support could be a huge help, but our system just isn't well set up to have those available to individuals and to have it funded. And so I'd love to see how we could, that full continuum of care, like Amy said, and really thinking about where is it sort of concentrated, but where is it missing, but could have major impact.
That is great thinking. It makes all the sense in the world to me, but I think would be revolutionary in some circles. So I will definitely become a carrier for that message within NIAAA, or do my best to do that. And we have a very linear approach and fixed, it seems, approach to recovery services and treatment services. And we need to shake that up. I couldn't agree with you more. Could we turn now to discuss the role of race, ethnicity, family supports, and culture in recovery?
Well, I'm happy to take a stab at that, since I've done a lot of work on racial ethnic disparities and thought about this question. As I thought about this panel, I realized that there is very little that we absolutely know for sure in regards to disparities in recovery outcomes across race, ethnicity. there just aren't a lot of data. Treatment studies generally have been short-term and have not looked across racial ethnic groups. And then in the epi world, there's been a little bit of analysis of the NESARC data, a handful of studies there looking at AUD remission and SUD remission to some extent. And but you know, the results haven't been replicated, and those are sort of older data. So, and you know, results don't hold up in multivariate analyses, or it's numbers can be small. So it's a little hard to know what to conclude in regards to whether there are really differences that we need to pay attention to in recovery outcomes for racial ethnic minorities. That said, I think there are real reasons to think that there might be disparities here. One is that racial ethnic minorities, and particularly I'm going to talk about Black and Latinx populations, are using treatment and mutual help groups less than whites. I'm just focusing on those groups because there's less evidence on other racial ethnic groups just because the numbers tend to be small, but there are very substantial disparities that we know about in treatment utilization, treatment retention, and participation in mutual help groups, particularly for Latinx populations, Latinx immigrants, and Latinas. There's some evidence for disparities for Black versus white people with substance use disorders as well, mostly along the same outcomes, although for SUD, formal specialty treatment participation, it seems like there's less evidence, it's a little more mixed, and it's maybe more just for women. But so those are substantial and replicable disparities, right? They've been replicated in many studies. For example, we did a study with the National Alcohol Survey finding that Latina women, the rates of formal, that is specialty substance use treatment among Latina women were almost as low as a third of what they were among white women. So among those with alcohol use disorders. So, you know, this suggests that recovery might be harder for racial ethnic minorities because treatment is one major support for recovery, right? There are also limitations in access to screening and brief interventions because racial ethnic minorities are less likely to frequent a lot of the settings in which these interventions happen. So that's primary care and college settings. And so they're getting less in terms of intervention, right? And then finally, I would just make the point that, you know, there are theoretical reasons to expect that recovery might be harder even outside of access to, you know, these recovery related services. So racial ethnic minorities are more exposed to all the things that make recovery hard, right? Like poverty, housing instability, unemployment, social stressors, violence in the neighborhood, segregation, discrimination, and so on. So although we haven't titled those pieces together, you know, there's good reason to expect that recovery can be harder among racial ethnic minority communities, and there needs to be more work on this question.
Absolutely. Thank you, Dr. Seymour. Are there other thoughts from our panelists about this? You know, the structural issues almost go without saying. And I would be interested in hearing some of your thinking about the content of recovery services and the structure of how they're delivered and how that might be alienating to other than majority populations.
So I can weigh in here, and Sarah, I really like where you left off. I mean, I think that you we're just talking about all the key social determinants of health. You know, you were talking about that in terms of the context of how it may impact recovery. And I think that there's a clear connection between these social determinants of health and access to recovery, and how social determinants of health may affect recovery capital and sustaining and achieving recovery. So I just wanted to say that. But I can also talk about one kind of recovery support service, and this, Dr. Roach, wasn't a population that you mentioned, but I have done research on sexual minorities and access to treatment and recovery support services. And I was really lucky to have the opportunity to study a group of recovery homes in Texas that was operated by the same provider. There were 10 homes, and one of the homes was specifically designated as a recovery residence for gay and bisexual men. And I feel like I was really excited, and it was a really fortunate opportunity for me to study that, because gay, bisexual, and other men who have sex with men have been found to be at increased risk for substance use disorders. In fact, back in the 90s, the confluence of increased substance use, experiencing violence, and HIV/AIDS had a special term. It was called the SABA syndemic, because these conditions were so co-occurring and mutually reinforcing. And what was thought to drive that? It was really sexual minority stress. So minority men encounter some of the same risk factors for substance use disorders as other men, but they also experience additional risk factors that are unique to that population. So stigma, prejudice, discrimination, that's often referred to or described as minority stress, which create kind of a hostile environment that increases risk for a whole host of negative conditions, including substance use disorders. And paradoxically, solidarity and cohesiveness within the gay community can serve as a critical resource to buffer this minority stress. But substance use is common in places where sexual minority men may go to spend time with their peers, such as within bars or clubs, or even neighborhoods as social enclaves. So these settings may not only elevate risk for substance use disorders, but also prevent or present obstacles to recovery, because the research is pretty strong in that a very consistent predictor of relapse and substance use disorder is members of your social network being drinkers or substance users. So developing communities and social connections among sexual minority men is really incredibly important. And so, the opportunity I had to study this recovery residence that was specifically for sexual minority men, providing them an opportunity to make connections with their peers in recovery who also shared their identity as a sexual minority, was just amazing. It was a small pilot study. It was a NIDA-funded study. It was a 2-year study. We were able to recruit 25 gay and bisexual men, sexual minority men, and we followed them at baseline and 3 months into their recovery journey. And they were eligible for the study regardless of whether they decided to live in the gay and bisexual men's home, or if they went into one of the other men's homes. And we looked at differences, between those who chose to go into the gay bi men's home and those who, chose to live in one of the other men's houses. And we saw some very interesting differences. So there were differences at baseline in terms of problem severity and kind of the drug use profile and the level of medical and other problem severity with the men who chose to go into the gay and bisexual men's homes, kind of having indicators of greater problem severity than those who went into the other men's houses. And we also looked at, why, or kind of their stated reasons. We were able to collect some qualitative data, their stated reasons for moving into one home versus the other, and kind of what they were hoping to gain in their recovery experience, or their experience in the recovery home. And men pretty much uniformly were, talking about social and emotional support and accountability. That's what they were looking for in their recovery home experience. But those men who went into the gay and bisexual men's home were really talking more about social and emotional support within the context of safety, social and emotional safety in that context of support. Interestingly, we didn't find differences in outcome. We saw really positive, outcomes for men in both, who, regardless of the house they went into, in terms of days abstinence, connections with treatment and recovery support services, and also negative coping skills decreased at follow-up. We also saw a decrease in health-related quality of life, which is interesting, and kind of makes me think back to Dr. Kelly's presentation with the burning house analogy, and kind of what may happen when the smoke clears. But again, this really underscored for me, this work, the importance of the social determinants of health, and thinking about subgroups who may need additional support within their recovery, and making sure that we have services that are available to address those needs. So sorry for the long kind of jag on my research, but I think it's a really nice way for us to think about social determinants of health and recovery.
Absolutely, and I very interesting to me, this notion of community, having within the treatment program. And I apologize to all of you if my prior comments seem to minimize the importance of social determinants of health. Saying that it goes without saying. I absolutely, this is to me the most important topic within this whole arena. So I didn't mean to suggest that. What I meant to suggest, thinking about them can be overwhelming. And, I'm eager to hear about how programs are addressing these determinants and having some impact on them. So yes, this is absolutely essential in this conversation. Dr. Shido, would you like to add?
Yeah, I think the way I view you started with sort of race and culture questions, and I think if I think of it from, and maybe it's old school to talk about the socio-ecological model, but we know a lot about what drives behavior and what barriers are out there from using that type of conceptualization. And I think that if we think about the social determinants of health, those are like the drivers of what a person is, what's going on in their life, and what behaviors and choices they're having, but in part driven by what choices are available to them, and sort of thinking of the layers of the ecology to understand, yes, the intentions piece is there, but what are the other levels of the ecology, all the way out to the funding and policy levels that impact what they have available to them and what's going on in their lives, and what social determinants are there present for them as an individual. And so I think from that side, but then also from the treatment and the services side and the recovery side is, within that, social determinants of health is one end of the drivers of things, but the recovery capital piece is sort of the positive end of it, of how do we get someone out of what it should be determined into recovery or success, or even preventing those determinants from having that impact. And that also, I think, is thinking ecologically of how those can be strengths, and the capital, how can they be turned into capital? How can someone's affiliation from race or or their identities, or what their ecology looks like, the factors in their community, SES, how can things be taken into account as part of treatment and services, and as part of individualizing the services to that individual, and what's important to them, and what's impacting them or not, because things may be present but not having an impact on them, and not making assumptions one way or the other for that individual. And then how can we, what elements of those can actually be turned into strength to help that person build and come on the backside of the difficulties they may go on through. So again, I sort of use that socio-ecological conceptualization from start to finish, but I think that incorporates the social determinants that result in whatever's going on, and then how we might see the person and help them to move away from that.
Thank you. It speaks to me of the critical importance of collaboration with other service providers and in other arenas. The treatment system cannot do this alone, or the addiction treatment continuum cannot go about this alone. There's no way, absolutely. Any other comments on the social determinants issue?
So I want to add one other thing. So when I think about social determinants of health, I also think about issues of access and availability to care. So I mentioned the NIDA-funded study looking at recovery among sexual minority men. I forgot to mention that when I did that study, part of the reason why I was so fortunate to do it is that was the only home in Texas that served a segment of the sexual minority population, the LGBT community. And I think that at the time, and this was probably around 2016, was the only house that was part of the National Recovery Residences, or National Alliance for Recovery Residences affiliated programs across the country. You know, in speaking of access and availability, there wasn't a lot of, you know, treatment or recovery support for folks. And in fact, you know, some of the men in those that we enrolled in the study had come from other states to that recovery home in Texas because there was just so limited availability. And I also want to, you know, talk a little bit about another study that I work on, the NSTAR study, which is the National Study of Treatment Addiction Recovery Residences, and that's funded by NIAAA. And that study, you know, does a couple of things with respect to recovery housing. You know, it wants to, well, it mainly wants to do a stratified random sample of recovery housing across the country. We have really good research on Oxford houses, really good research on halfway houses in therapeutic communities, some, you know, emerging research that's strong on sober living houses in California. But if you're not one of those types of programs, you know, what is, you know, the research say about your kind of program? So, you know, really thinking about what recovery housing is and what it looks like across the country, across the spectrum of all different kinds of recovery housing. But in order to do a nationally representative study, we had to have a sampling frame, a listing of all recovery residences in the country, and that didn't exist. Well, I don't think it exists yet. So we built a database of all the recovery residences in the country from lots of different sources. But in the context of, you know, building that database, that sampling frame, we were able to collect geolocated information. So we were able to map and to look at the distribution of recovery residences across the country, to really look at the availability of recovery housing and look at potential disparities, geographic disparities. With the geolocated data, we can also look at the community context in which recovery residences are located to get a better understanding of the, you know, the neighborhood factors that may impinge upon the recovery of people who are accessing those services. I know that we don't want to do slides, but I do have slides available that shows the distribution of recovery housing across the country. And we've done some multi-level modeling looking at predictors of recovery housing and where it's located. I don't know if this would be surprising to folks, but you know, the recovery residences are more likely to be located in urban areas. meaning that, we have a long way to go to make sure that all people have access to recovery housing. There are many states where there's very limited recovery housing. And so again, that, speaks to social determinative health of just having access to that kind of recovery support, and that part of the substance use continuum of care.
Absolutely. I wish we had time to look at your slides. I'd be fascinated. But this just speaks to the need to continue this conversation beyond the summit. So let's think about how we can do that. We are rapidly running out of time, and I have lots of, really, I think, important and interesting questions to ask you. So I'm going to try to get quickly through a few of these and ask you to limit your, give me the short version of your response. And I promise we'll create another opportunity to continue. But one question I really weighs on my mind a lot is gender differences in the recovery journey, and how one's gender influences the journey.
No, that might be hard
because this isn't an area.
Go ahead. I have studied gender in relation to race, ethnicity, and I will say that the intersection between race, ethnicity, and gender is incredibly important. A lot of times I'm finding that disparities emerge particularly among racial ethnic minority women, or are stronger among women. So in terms of how recovery is related to gender overall, I probably can't speak to that as well. I don't know about anyone else on the panel.
Any thoughts from your, even if it's not research-based, from your wisdom of experience?
Yeah.
I'll add something here. Am I speaking over them? This is Dr. B again. Here's something to think about. We know that 1 out of 10 women who go to treatment are able to retain their partner in recovery. And 9 out of women who have a male partner, this is when they're on the binary scale, who have a male partner who goes to treatment, stay with their partner when he returns and assist him in recovery. That disparity in how we get help in every area of our life from the opposite sex is amplified in this area. And there are lots of thoughts about why that gender disparity exists in recovery, and just the way someone in recovery begins to advocate for their self in a different way, and would be seen as being different in a relationship in recovery than they were when they were using, begins to take on a lot of importance. The gender differences in use, the gender response to substances, the role of the periodic cycle in the menstrual cycle in women has been written about. Any of our participants who would like to get an article, a review article that I wrote with several other women from ASAM on that, I'm happy to send it to you if you put a note in the thing. And that was something I remember you encouraged me to do when you brought me in, Deirdre, to speak to NIAAA about it. And my first opportunity to speak about that came in doing an NIH talk with Sheila Bloom back in the mid-1980s, when she was very clear about policy differences as it related to women, but she could get no one to speak on this panel with her at NIH because there was no information available about women and drugs. And I was so stupid that I agreed to speak with her, not knowing there'd be nothing to say. So I had to finally make it about what we didn't know, and we've closed the gap. So there's a lot that's been written about it, and we're really able to address that more. And I'm happy to send anybody the paper that we wrote.